Hello, everyone, and welcome to the CoROM podcast. This is where academic medicine meets remote, austere, and resource-limited areas.
Oh, brilliant, guys. Thank you so much for joining us in this first session of managing dental pain. I've got a bit of a sore throat, but still I have a drink of hot water close to me and we'll carry on. So you can stop me anytime you want with any questions you want, right? So let us just deal with dental problems. Now, dental problems which anyone comes to you with is essentially when they're saying they're complaining of facial pain, it is either related to the tooth, it's related to the gums, or it's related to the face. So what I've decided is try to work our way through certain cases and learn from those cases, right? So here is, it's essentially me using AI, complaining of sensitivity. So when a patient comes to you complaining of sensitivity, what are the two most important questions which you will ask about the characteristics of this particular dental or facial sensitivity? Now, the two most important things which I would want to know is the duration and the location. So what do I mean by the duration? By duration, I mean, is the sensitivity or the pain of a very short duration, i.e., once the stimulus goes away, the pain goes away? Or is it a situation where there is a stimulus, there is pain, and when the stimulus goes away, the pain continues? So that is very, very important. Now, which of these two is the more worrying one? So for both of them, I would be worried if the casualty says or the patient says that the pain continues even after the stimulus stops. I eat something cold, it causes a lot of pain. I've stopped eating, let's say, the ice cream, but the pain lasts for 15, 20, 30 minutes after that. Now, why would I be worried of that particular scenario? That is because the irritation which has reached the center of the tooth, which is the pulp, is now sufficiently big to irritate the pulp to a sufficient extent that it started getting inflamed. Now, where has this irritation come from? This irritation could have come from through the tooth, i.e., through a hole, a broken filling, or a decay, or it could have come through the gums, like a gum infection, where the infection has gone through the gums, through the bone, into the tooth, causing that degree of irritation. So let us look at the scenario about location. What do we mean by that? By that, it means that the patient can locate exactly which tooth is sensitive. So he says definitely the sensitivity is on the third tooth from the front. Okay, that's one scenario. And the second one is that the patient says, I've got pain on the left side of my face, and I cannot figure out whether the pain is from the top tooth or the bottom tooth. The entire side of my face hurts. So which of these two is the more worrying one? The more worrying one would be when the patient says they cannot locate where the pain is coming from. Now, why is that worrying? So the irritation has gone through into the central part of the tooth, i.e., through the tooth at the top or from the gums around. Okay, it has caused a swelling in the center part of the tooth. But the center part of the tooth has got no receptors. The pulp has got no receptors to locate where the pain or where is the location of the pain. So that means the inflammation has reached the central aspect of the tooth. So you notice that if you have this issue and you go to the dentist taps the teeth. Why do we do that? Is that we are trying to stimulate the nerves in the bone at the bottom of the tooth to try to locate which particular tooth is the naughty one. And the reason is that the bone around the tooth has the receptors which gives you the location where the pain is. So the center of the tooth doesn't, but the nerves around the tooth in the bone do have those receptors. Okay? Now, what will you do? So we have this casualty who's complaining of a short-term sensitivity and can locate exactly which tooth is causing him or her the pain. Okay? And we look into the mouth, and that is the picture what we see. So it is a tooth. It shows the gum line of the teeth, and you see there's recession. The gums have gone below, exposing the neck of the teeth. This is very, very common. So what has caused that? Now, when you ask the patient says, I really look after my teeth well, but that could result in aggressive tooth brushing. Okay. So therefore, the patient is scrubbing the teeth really, really hard and has pushed the gums down, exposing the neck of the teeth. Now, there are lots of nerves around the neck of the teeth, and that is causing the sensitivity. So what we want to do is to reduce the cause or stop the cause. So we can tell the patient not to brush their teeth aggressively. Now, this is really hard to do for anyone because, like my wife, if you're used to aggressive brushing, it's really hard to stop that. So therefore, what can we do then? The first thing is tell the patient to shift their toothbrush from the hard one to a soft or medium one. Even better, if they have access to an electric toothbrush, to use that. Why? Because most electric toothbrushes have a pressure sensor. As soon as you put excess pressure, they sort of back off. That's one. Secondly, we need to put some medicine around the gum line of the teeth. Now, what medicine will you have access to? Simple medicine which you'll have access to. The most common one would be an anti-sensitive toothpaste. Now, there are two types essentially of anti-sensitive toothpaste. One is the one which acts immediately, right? Rapid acting one. And the one is the other normal one. So for these patients, you could possibly select the rapid acting one, but you got to understand the difference between these. What does a rapid acting anti-sensitive toothpaste do? They don't treat the sensitivity. They essentially numb the teeth. It's like, for example, if you've got a headache because your vision is getting bad, you take a painkiller, your headache goes. But you still haven't got classes to correct the vision. It'll just come back. So that is what the anti-sensitivity, the rapid ones do. They just numb the teeth, okay? So how do we tell them to do it? What is the dosage? Like any medicine, toothpaste is a medicine. It needs a dosage. So you tell the patient to have their breakfast, then brush their teeth like they normally do, then take a bit of extra toothpaste, rub it along the gum line of the teeth, spit, don't rinse, try to leave the toothpaste as long as possible on the gum line of the teeth. And the same thing, we do this in the afternoon and at night time. So 3 times a day to be left as long as possible on the teeth, not to be rinsed out. So that would control the immediate sensitivity. For the long term, to deal with this issue, they will then have to go onto a normal toothpaste or normal anti-sensitivity toothpaste. Now, there are 2 types of those. One is by Colgate, which uses arginine, and one is by Sensodyne, which uses Novamin. What those do, they actually block the porous region along the gum lines of the tooth and block the sensory stimuli from going through. But they do take, in spite of all the advertisements, they do take 2 to 3 to 4 weeks before they act fully. Okay, I just seen it on the comments. Somebody says they use clove oil. Now, how does clove oil work? Clove oil is good, but you got to know how to use it. Okay, and everyone loves it. Clove oil is an astringent. So what it does, it precipitates proteins. Essentially, when you take an egg and you boil it, you get egg white. So what clove oil does, it chemically does what the boiling did to the egg white. It precipitates the proteins, okay? But this will act, and it's also slightly antiseptic, slightly anti-inflammatory. So you can use it in a reasonable cavity to do it. But on the gums or close to the gums, we would try not using it because it acts as a chemical irritant. It will precipitate proteins on the gums. So initially it will act really well and you'll feel really good. But after the second and third application, it will cause an ulcer to form on the gums, or it'll cause a white patch to form on the gums, which is a chemical burn. And then it gets worse before it gets better. So whatever we do with clove, ideally it should not come in contact with the gums. If you're using it within the teeth, the pellet which you use, if you're using clove oil, it should be damp with it, not dripping wet with it. It should be damp with it, and it should not come in contact with the gums. Initially, it'll be good, and it'll be good because it's precipitate proteins on the nerve endings in that area. So you'll deal with the pain, but later on, it will cause a chemical burn, which will make the situation worse, if not better. Okay? So let's go to the next. Feel free to ask me any questions in between, yeah? Right. Now we come to this scenario where the patient says that I've eaten a hot egg and suddenly I've got a lot of pain on the side of my face. I immediately stopped eating it, but the pain continues for 20, 30 minutes and I cannot localize where it is coming from. Okay, so this is what you see clinically. You see a tooth and you see food stuck between the teeth. So what will you do then? So the idea is you want to get rid of the cause. Now, you've seen food between the teeth, and that should not be there. So that is possibly the cause. So the first thing what you would do is grab a piece of floss and try to get rid of the food. What will happen when you do that is 2 things. Patient will complain of pain and patient will complain of bleeding. Okay? Why? Because food is stuck between the teeth. This food is irritating the gums. Irritated gums are inflamed and irritated gums are painful. So as soon as you put your floss into it, it'll be bleeding, it'll be painful, it'll be tender. But you would have got rid of the food from there. So at that point, I hope you all will start thinking, why is this patient not flossing or getting rid of the food between their teeth better? And the most common cause is that the patient says, whenever they floss, it bleeds. Whenever they floss, it hurts. Why? Is because they are not flossing. So food is building up between the teeth, irritating the gums, irritated gums bleed, and they're painful. And that's why they stop. So ideally, wherever in the mouth they are having bleeding, any location, you have to concentrate more on that area, not less on that area, because you got to get rid of all that irritation, which is irritating the gums in that area. The other thing with patients are worried about is that they think the teeth will separate when they floss. They can't do that. It's ridiculous. The teeth, they think the teeth will break in between when they're flossing. Now, floss is a thread. Impossible, ridiculously impossible for it to break the teeth. And you tell them that it's ridiculously impossible to break teeth when you floss, okay? The other thing they're worried about is when they floss, the fillings will come out or it'll get stuck. That is a valid concern. So when your floss goes in and gets stuck, tell them to pull it out horizontally, not vertically, okay? So you've given all these instructions to this patient. You told them it's ridiculous to think that the tooth is going to break when you floss, and the patient goes away. Starts flossing regularly, and after 3 days comes back with a broken tooth. And then says, you told me it's ridiculous that the tooth is going to break, and now I've got a broken tooth. Why did that happen? It's not the floss which did that. It was the food getting stuck between the teeth, giving rise to acids. The acids went through the tooth, through the enamel of the tooth, went into the dentine, spread laterally into the dentine. So the outer part of the tooth, which is the enamel, is now hollow, thin, because there's no support, and that cracks and breaks open when they eat anything relatively hard or even by soft things like flossing. So now what are you going to do about that? So essentially, you got to clean it and pack it. Okay?
I have one question, doctor. Would you
Shoot.
would you not already say to the patient that this might happen if he gets the floss? Because if he returns and you address that concern in such a way that you say like it will not break the tooth, he might lose confidence in you, and maybe he will not return even because he will think that you said something that turned out not to be true.
Very good question. So let's rephrase that. You would tell the patient that a floss, because if you tell the patient at the start, yeah, that the floss could break the tooth or separate the tooth, he's not going to do it. Okay?
Of course.
So therefore, very good point. So how do we paraphrase that? We tell them that when you're flossing, it will not break, it will not separate the teeth. However, if there is a deep hole in the teeth or the sides of the teeth, then that could happen. But that would happen sooner or later anywhere when they are eating or just normally on itself because it'll be hollow. But you're right, it may be a good idea to establish that direction at the start. I agree wholeheartedly with you.
Yeah, thank you, doctor.
No worry, good question. Kevin, is it?
Yeah, sir. We met before the MIM before. Yeah.
Oh, brilliant. Are you coming to Malta this time too?
Unfortunately not. Yeah, I'm in Suriname currently.
We'll miss you. Right. Let's go to how do we do this filling? Okay. How we do the filling is, let's start with the position of the patient's head. Now, basically, dentists use indirect vision, but you guys might want direct vision. So in direct vision, if you're working on the lower teeth, the lowers will be parallel to the floor, uppers which will be at an angle of 45 degrees. So you have direct vision of the lower teeth. If you're working on the top teeth, it is like a tracheostomy position. Neck extended, head rotated, so you have direct visualization of the top teeth. Yeah? Now, next place is like, just if Abrick, if you can tell me if you can hear the sound of this video or not, otherwise I'll speak it through.
Yeah, no sound.
Okay. So you have the assistant holds the head on either side, and therefore you rest it on the patient's chest. So you come as close to the patient's chest and you hold the head close to your chest, the assistant's head. That way the patient cannot move around and do that. Yeah. You got that bit? So basically, if you have an assistant, tell the assistant to stand behind the patient and hold the patient's head on either side. So when you're holding the patient's head, make sure the bottom few fingers are on the lower jaw, one finger is at least on the upper jaw, then your fingers separate. So you try not covering the ear so you can give the instructions, patient can hear it better, and the assistant can move around and make sure that the patient does not move the head. Okay, that was the whole clue behind it. The next thing is you got to clean the teeth. Now, how do we clean the teeth? If you have this spoony instrument known as an excavator, it is like a spoon or a bony curette. We put that into the decay closest to the center of the tooth and we clean away from the center of the tooth. Now, why do we clean away from the center of the tooth and not towards the center of the tooth? Is if your instrument slips and if you're cleaning away from the center of the tooth, it's fine. But if you're cleaning towards the center of the tooth and it slips, it can enter into the central part of the tooth, which is your pulp chamber. So that is why you clean away. So I'll just show you a video on how that's done. So you're cleaning away from the center of the tooth. What is the consistency of the decay? The consistency of the decay is like soft cheese or like soft mush. As you clean it and as you get more and more of it out, it starts getting harder and harder. Then it reaches the consistency of like wood shavings. But sometimes it's better to leave a bit of the decay behind rather than getting too pedantic of cleaning as much as possible and entering into the nerve chamber. Okay. Next thing, we want to dry the tooth and keep it dry. Now, how do we do that? Is that we have to stop the flow of saliva into the tooth. So we can, if you're working on the top teeth, we can roll some cotton rolls and stick it onto the cheek side of the upper molars. What is it doing? Is reducing the flow of saliva from the parotid duct into the mouth. Okay. Now, if you're working on the lower teeth, do the same as you did on the top teeth, but then roll some cotton rolls and put it on the tongue and on the cheek side of the tooth you're going to be working on. Okay, because we want the teeth to be dry and not flooded with saliva when we are working on it. Now, which filling material are you going to use? You may open your kit and find the following commonly used filling materials. One is called Cavit or Coltine, which we all have seen, which is pre-mixed. It looks like putty, very easy to use. The other two are like powder and liquid. You have to mix powder and liquid together to do it. Now, which one is ideal for our patients? The one which we advise you guys to fill cavities in a patient mouth is Cavit. Why? It's really easy to use. It is like a putty. It's pre-mixed. Okay. You scoop it out and you push it into the hole. Okay. Now, when you push it into the hole, how does it stay in the hole? It is mechanically locked. So basically, the sides of the teeth is holding it in place. And many people ask, how long will it last for as a temporary filling? The answer I give is, if you are doing it, is to tell the patient it could last for a day, it could last for a week, it could last for a month. So always reduce the patient's expectations. That's what I feel. But how long will it really last for? Essentially, it depends on how many walls of the teeth are intact. So if the hole is only on the top part of the tooth and all the surrounding walls are intact, it'll last for a long time because it's not mechanically locked. If one wall is missing, 3 walls are intact, it could possibly come out sooner. If 2 walls are missing, 2 walls are intact, it could come out even sooner. If 1 wall is left, all the 3 walls are missing, it could come out even sooner. So therefore, it depends on how many walls are left to hold it in place. It is made of zinc oxide. Zinc oxide is a cooling material. It cools the teeth down. It is not irritating. How does it set? It is the moisture in the mouth that makes it set. So that is why it's such a good material. The other materials, another tip is, like, if you're doing it in cold weather and you open the tub, you'll find that this pasty or supposedly pasty putty-like material is very powdery. That does not mean it's gone off. All you have to do is to scoop it out, massage it in your fingers, the oils come back into the surface and it becomes putty-like again, okay? Now, the other 2 materials which you could possibly have in your kit, and I hope you do, is these 2. They're powder and liquid, okay? Class ionomer or polyF. PolyF is very often present in American kits. Class ionomer is very often present in the British kits. This is not what we advise for you to fill deep or moderately deep holes in the teeth. Why? A, it's more fiddlier to use. You got to mix it, powder and liquid. That's 1. 2, it is harder to use because very, very sticky. It sticks to everything. 3, not only does it stick to everything, but it also sticks to the tooth. It chemically bonds to the tooth. 4, it is sets very, very hard. So if you want to take it out, it is very hard to get it out. So why is this in your kit? And why do we recommend you guys to keep it in your kit? Because if, for example, which we will discuss in our future talks, if a big container lands on the casualty's front tooth and chips his front tooth out, these liquids or these cements are very good intraoral bandages because they stick chemically to the teeth. So they have also, if you want to put a splint and attach it inside the mouth, again, this is very good to hold the splint onto the teeth in the mouth because they chemically bond to the teeth. And yes, class ionomer is the same thing as Fuji 9, especially if you're covering sporting events. If you're working on offshore, I strongly recommend that you have a Cavit-based filling material as well as glass ionomer-based filling material in your kit. I think it's an absolute necessity. And last year, at least, we had to send 4 off urgently with people covering sporting events who had not taken it with them. Right, now, how will we place the Cavit into the hole? So basically, you scoop it out, you roll it into the ball, you roll the ball into the cylinder. Now, in this cylindrical object, one end will be sharp. You take your metal instrument, cut off the end of this cylindrical filling material, carry it to the tooth, pop it into the tooth. Finger is a very, very good instrument, and you use your finger to push it in. I'll just show you a video. So here we go. We scoop it out with a metal flat plastic instrument or flat metal instrument. Then you see how we massage it. We roll it. We pop it into the tooth. We put a wet cotton, which which like bonds it, pushes it to the sides of the teeth, as well as starts a setting material, and then the patient can bite on it, so it's firmly within the tooth. What are the post-filling instructions? Basically, this material will take 20 to 30 minutes to set. The patient can eat after 2 to 3 hours. In the first 24 hours, I would recommend you tell the patient to go onto a soft diet and to be eaten from the opposite side of the mouth, just being slightly more safer in that respect. Okay. Right. Now, what if you don't have any instruments and if you don't have any filling materials? How can you improvise? So I'm just going to stop here briefly and ask if there are any questions.
Hey, Doc. I'm sorry I had a little trouble with
Dange, hi, how are you doing?
Hello. Good.
Hi. Nice seeing you.
I'm super excited to be able to listen to you. I'm sorry, I'm having a little trouble with the connection. That's why I keep interrupting by accident. But I may have missed this. Did you talk about salt gargles and before when you were talking about the recession? Have you found any benefit with that, or as being as good? I don't know, analgesic.
So good question, Tange. So salt water is, what does salt water do? So A is the temperature, it's warm-ish. Salt is again an astringent, it precipitates proteins. It has slight antiseptic properties also, but for the tooth perspective, for where the pain is caused by gum recession and exposing the neck of the tooth, where the pain is coming from the exposed nerve endings in the tooth structure, the neck of the teeth, the salt water will not help. What the salt water will help in is reducing inflammation associated with the gums, preventing secondary infection when you have nothing around. So let us give some examples. Let's start with the smallest one. If you have ulcers in the mouth, like normal oral ulcers, these ulcers last for usually 7 to 10 days. You do not, however, if they get infected further, they will last longer. So if you do salt water, agreed they will sting, but they will do two things. They'll deposit an astringent layer, so they'll deposit proteins around that area. Because of the warmth, they'll wash area pretty clean because the solubility will be high, and they will tend to reduce secondary infection, possibly shorten the time of healing. But where salt water definitely comes on its own is where, for example, if you have a young person on your rig and they complain of difficulty in opening mouth and an excessive pain associated with his back tooth. So you look into the back tooth and you find that it is actually a wisdom tooth. And you find a part of the wisdom tooth is come out into the mouth, but most of it is covered by really inflamed, angry gums. Okay. So what has happened is that the wisdom tooth is partly in the mouth, covered by the gums, but there is a pocket between the tooth and these gums. It's quite hard to clean in that pocket. So food and debris tends to collect in the pocket, causing the inflammation of the gums covering this wisdom tooth. And this gums get so inflamed that they close the opening of the pocket. So now you have a cave with food and debris collected. And the worst thing is that the gums around it are so inflamed that now the top teeth start biting on it, worsening this whole situation. So what can you do? You don't have any fancy medication with you. What you can do is take a wide bore needle, green needle will do, preferably blunt. You will load it with lukewarm salt water. You will put some lignocaine cream around into those gums if you can reach it. Wait for 2 minutes, then slide the needle into the pocket between the tooth and gums and gently wash it off. And you will notice first it starts bleeding a bit, then all the muck starts coming out, And that really cuts down the inflammation, increases the comfort of the patient, and you dealt with it locally. In a situation like this, sometimes the patient even has an extraoral swelling, in which case they will also need a course of antibiotics. So that is one place where you use salt water. Another place where you can think of using salt water is that when you see a gum abscess forming between the tooth and the gums on the sides, similarly things are formed. You have a tooth, you have a pocket between the tooth and the gums. Food and debris is collected in this pocket. It's irritated the wall of the pocket, which gets so inflamed that it closes its own opening up. But now you have an abscess on the side of the tooth. What you can do is, again, put some lignocaine cream in. First dry it, put lignocaine cream in, put another cotton swab, wait for 2 minutes, take the cotton swab out, take a blunt needle, bend it at 90 degrees, push it in the space between the teeth and the gums, and gently wash it off so it gets clean of all that debris and helps it in releasing the pressure pain which is there in that area. If the patient has got an extraoral swelling or worse, you will or may have to give a course of antibiotics.
Thank you so much. That was an amazing answer. And thank you for explaining the pathology.
So now what if you have no instruments, no filling materials, and the patient comes to you, says, I've broken my tooth, it's hurting, and there's a gnawing pain in that area. What can you do? Essentially, let's think of the physics. Why is that a problem? The problem is food is getting stuck there. Yeah. This food is being pushed between the teeth and the gums, creating a pocket, which we are just talking about. This causes a lot of inflammation. So what do you need to do is get rid of all that food. What can you have to get rid of all that food? If you don't have any special metal instruments, at least you could have a floss. Or if you don't have a floss, you could have a toothpick. You could have a sharpish piece of wood. Essentially, it's the physics. You want to get rid of that stuck food in that area. As soon as you get rid of the stuck food in that area, you get rid of the decaying food in that area. You get rid of the decaying food in that area, you get rid of the chemicals released by the decaying food. These chemicals, which are irritating the gums, also the mechanical pressure of the food being impacted between the teeth and the gums. You're getting rid of all that stuff. So once you get rid of all that stuff, you need to put a filling into that area. Now, if you don't have a filling, what you can use soft wax. You can use other beeswax, mastia, which is like a gummy stuff, sugar-free chewing gum. But what all these do is that though they occupy that hole, prevent food from getting pushed in, they do have one big problem. And the one big problem is that they do not seal the space between the filling, which is any of these materials, and the tooth. So now you have a confined tight space, like in the margin of this filling, or in the tight space between the filling and the tooth, where liquid, which is your saliva, full of dirt and food, is seeping in there and collecting in this dark, cozy environment, giving off acids, giving off bugs. So what do we compromise? What you can do is, yes, you can do this, but ideally, every day, you'll have to pluck it out, clean it with toothbrush, toothpaste, get rid of everything, and then possibly replace it back. Or you can get smart and carry a tub of temporary filling with you, and then you won't have to think of all that. Yeah. But again, as Abrick says, we have to learn how to improvise, because if we don't have anything, we have to learn what to do about it, right? When will you not fill a tooth? When will you leave the hole open? Essentially, if the tooth with the hole in it, on the cheek side or the tongue side of it, is inflamed. If you put your finger in that area and touch it, that the patient starts feeling pain or tenderness on touching, you might want to think twice whether you want to close this hole. Okay. Others is if you have a swelling adjacent to that tooth, then you don't want to fill that tooth. Why? Because why is there a swelling? Or the dead meat and acid has gone through the tooth, through the bone, into the gums. So basically, you want to keep the hole open and clean to establish drainage of the acids and gases. You do not want to close it. And if you did not have any of these two situations and have done a filling, and then you get a swelling, pain, and tenderness, then you have to seriously think of getting that filling out, possibly giving antibiotics and analgesics, but getting that filling out and establishing drainage in that area. And that is why I said your filling material ideally should be like Cavit, and you might want to avoid things like class inomer, poly F plus, or the powder liquid ones, which set really hard. And that was the logic of my advice. So now you've done this filling in this patient, he's fine, no swelling there, he goes away, but 10 days later on, he complains of sinusitis. Okay. You look at his history says the patient has a history of sinusitis. You consult your doctor in charge, and they says that no, don't give antibiotics, try steam inhalations to allow drainage of the sinuses. And you pop him on steam inhalation to deal with the sinus problems. But what mistake you did was you did not tell your doctor in charge or whoever in charge or yourself, you did not remind yourself that you also had done a deep filling for this patient. You forgot about that part of it. You did not look into his mouth. You forgot about that part of it. So you went straight into his history, straight into sinus problems. By the way, we had this situation with a British Antarctic seaman, exactly like this. Okay, you did this. What happens is that because you put heat on the outside, the inflammation has now migrated to the outside, and you got a whopping cellulitis on the outside. Okay, so it's not the end of the world. This has happened, and it's developed quickly because you put heat on the outside. So cold is good, hot is bad. So should not put any heat on the outside. Okay. So then for these patients will need to be put on antibiotics quickly. You might want to think of Medivac soon, but something has to be done. Okay. Now, antibiotics. When should you give and what should you give? So there is a lot of discussion on that. So basically, if you ask any doctor or dentist in UK or USA about this, they say, no, we are against giving antibiotics because antibiotics don't work for teeth problems. Now, what is the reason behind that statement? The reason behind that statement is the source of the infection is inside the tooth, and that has given out dead meat. It's died, so dead meat has released acids and gases, which has come out of the tooth into the soft tissue spaces, causing all these problems. So the best thing what you can do is deal with the source. The source is the dead meat and the acids in the center of the teeth. There's no point giving antibiotics systemically when we can go in, take out all the dead meat, wash it off with antiseptics, and deal with it locally. Okay. But you do not have the skills, the tools, or the know-how how to do that. So in your situation, you cannot do that. So it's not that antibiotics will not act. The antibiotics will act, but it is not as good as dealing with it locally. So in your situations, you will have to seriously think of antibiotics for many of these patients. And when you give antibiotics, I always think you have to start earlier rather than later. So you don't have to wait till it becomes a full-fledged cellulitis or an abscess. You have to start when there's a little inflammation, infection, and you know it's gone into the bone, and you need to deal with it earlier rather than later. That is my personal opinion. Some of your doctors may not agree, but this is what I think. Again, what antibiotics will you give? Again, here in UK, we have step ladder. We go to the lowest one first and work our way higher. Where you guys are, you do not have the luxury of all this. You don't have the luxury for time. You do not have a luxury to deal with any complications, and you don't have a luxury of a wide range or choice of medicines. So in my personal opinion, you have to take a hammer to crack a walnut. So the bugs which you're dealing with are essentially anaerobic, okay? The next common ones is a mixture of anaerobic and aerobic, and the last ones are aerobic, so that's the least, okay? If the patients are not sensitive to or allergic to penicillin, you would give something like augmentin, which is ideally one of the best ones. If you do not have access to that, like many places where we go for humanitarian work, we don't have access to augmentin, in which case it works sometimes even better, is a combination of amoxicillin and metronidazole. It works very, very well. If they're allergic to penicillin, then clindamycin or a combination of any of those will do. Again, for pain relief, you need anti-inflammatories. So paracetamol is good, but you need anti-inflammatory. So you do need ibuprofen. And if it's too bad, you can combine ibuprofen with paracetamol, but you do need an anti-inflammatory. Why? Because the pain is a pressure pain, where the pressure is building up within the teeth or within the soft tissues or within the bone, and the periosteum, which is a tight covering around the bone, is holding it down. It's that pressure which is causing the pain, and you want to reduce the pressure. Hence, it's a combination of antibiotics and anti-inflammatories, but does it. However, you have to be careful that these patients are not dehydrated. They're not endurance sporting individuals which have their kidneys under a lot of stress, because ibuprofen has afferent arterial vasoconstriction. They put kidney under even more stress. So therefore, ibuprofen is to be avoided in those type of patients. Okay. So now you've done this filling. 4 weeks after this deep filling, the patient gets a gumboil. Now, why does this patient get a gumboil? So basically, you had the infection, okay? The deep hole in the tooth. It went through the tooth, it killed the pulp or the center part of the tooth. So your dead meat and acids now coming out of that center part of the tooth with the gases. It goes through the tooth, through the root, into the bone, and collects in the bone. Okay? And when that happens, the patient will start localizing where the pain is coming from. Because remember, I said there are proprioceptor receptors in the bone. So every time when the patient bites, the pressure goes through the tooth to the bone where the receptors can localize the pain. And the patient says, every time I bite, it hurts. Okay. The next stage is that this thing will build up pressure and go through the bone into the gums and will form a gum boil. So that is where you got a gum boil caused by the death of the tooth. Okay, so that's one gum boil. But now let us look at this. What is the difference between both of these gum boils? So the gum boil on this side is much further away from the crown of the tooth than the gum boil on the right hand side, which is much closer to the crown of the tooth. So the one on the left is related to the tooth. Dead tooth, dead meat acids goes through the bone, comes out through the bone, but comes out closer to the root apex. So hence it is much further away from the crown of the tooth. Yeah. Then the other one is close to the top part of the tooth, and that is caused by gum disease. So basically, what has happened is due to bad oral hygiene, you can see the food, the gums get irritated, and then there's a pocket which forms between the tooth and the gums. Okay, food and debris collects deeper and deeper and deeper into that pocket. It irritates the wall of the pocket. So the wall of the pocket is now irritated. There's a deep pocket, food and debris is collected, wall is irritated, and the whole inflammation is getting worse and worse. Now, with that food and debris, the wall of the pocket is irritated so much that it goes and closes its own opening up. So it is a cave where food and debris is collected. And that is the gum boil which you're seeing closer to the crown of the tooth. And that is caused by a gum abscess, not a tooth. The tooth could be fine. It is the gum which is causing that problem. Okay. Now, how to manage gum abscess and more we will discuss in the future discussions. And I've always been asked certain questions, and one of it is, what kit do you need? So if you all can use your cameras, you all can possibly get this. Ibrick, is that okay?
And that's on your website, isn't it?
Yep.
And you have tons and tons of things for free download. It's pretty amazing.
And no copyrights. You all can use it as much as you want. You don't even have to thank us for it or mention us for it. So that's one thing. It's a MP3 sort of, no, it is a video essentially of me teaching this. And the other one is differential diagnosis and management of dental pain. You can use that as even another nice one to keep your knowledge fresh.
Kevin, you have a question.
Yes, Abrick. I have actually 3 questions. It's doctor. It's actually very coincidentally, but I this week I will run along with the dentist here in Suriname, and I might be able to go 2 weeks to the mainland in the Amazon on a dentistry mission. That's not sure yet, but I had following questions about that. I know in Suriname, the health workers, they're not always dentists, but the health workers that work remote, they are taught to remove teeth as well. Is that something that you would promote us to learn as a skill? Or would you say as remote paramedics, we preferably focus ourselves on everything outside of dental removal?
So good questions. So first thing, what you got to perfect at or concentrate on your energies will be how to give local anesthesia. Okay.
Mm-hmm.
So you got to nail that down. You got to learn. So basically who you're working with is called dental therapists. They are very, very, very good, fantastic in teeth extractions. Okay. So, but they may not be that good. It depends on where you go in giving nerve blocks, doing mandibular nerve blocks, but they're very good at infiltrations. So as a remote paramedic, you can definitely give infiltration if you want to, depends on you guys, but nail down how to give local anesthesia. If they teach you how to give a mandibular nerve block, learn it. Why is it? It's that because it can get you out of a pickle. You can treat the acute pain, gives you time to think. And when you're remote, I think one is less worried about what you can or cannot do rather than what you have to do in that area. And as long as you warn the person you're doing this, play down their expectations, it should be fine. So now, when you're working on something which you're not that familiar with, the things which I tell all my students is make sure the patient who you're working on has eye protection. That's a must, because as you're concentrating on, you will develop blinds, you will develop tunnel vision, and you might forget the rest of his body. And therefore, it's very good to have some sort of glasses, preferably sunglasses, preferably dark. Secondly, tell them that this is not something I do routinely, but I've done enough practice on it so I could do fairly good at it. Thirdly, tell them your hands will shake because you would be exhausted, tired, worn out, end of day, doing something that you are not familiar with. So it is fine. Don't try to control it. It's fine. Now, the advantage of the face is very easy to get a 3-point support when you're doing it, because you have the cheeks, you have the teeth. So don't do freehand. Get 3-point support. always before you call the patient and set everything up, tell your assistant how the head should be held. Make sure you have a good head torch. Make sure besides your assistant and you, there's another person assisting you when you do the work. So ideally, there should be 3 of you all. This other person will shine the light, act as an assistant, retract the cheek. More hands do make lighter work. Next question is about your extraction. I think if you have an opportunity to learn, there is no harm done. If it is okay for you to learn, it's another skill. God knows when you will need it. And also, you may come across a scenario where you have a doctor working there and has to do the procedure, but is not that familiar with the procedure. Whereas you would have already done the procedure and you can suitably help the doctor in doing it and assist him in doing it. Or thirdly, you could go with a dentist. And like me, when I go for humanitarian deployments, we do like something like 200 patients a day. That is humanly impossible for me to do it, in which case we always train the others in the team to help as much as possible. So you could have another feather in your cap to make you an even more valuable member of the team. So that answers your question. Next question.
Yes, sir. My second question was, and we see that a lot here, that patients do not return. How would you approach that in terms of if you have an infected tooth and in terms of a medevac? Because we only have a few airplanes or boats, and we can only extract people certain times, amount of times a year, depending on how the river stands. And how would that implicate your decision to preventively medevac the patient or not?
So basically, so for that, the first thing, if I was you, the first thing I would do is, as you've all your findings, your signs and symptoms, you have to transmit it up the chain of command. Who is on top of you? You have to let them know every single thing which you have. And then, if you, as you say on your recent trip, are going with dental therapist and have just broadened your dental knowledge hugely, possibly more than the person who you're communicating with as you're up the chain of command, it is then that you could contribute into the discussion, but the final decision will be on the doctor or medic supervising you at the top. How would we prevent it is, like I kept saying, use a hammer to crack a walnut. You will give him antibiotics. You will give it early, but it depends on how long the patient is going to be stuck with you there. Because after a certain stage, the antibiotics are not going to work and it is going to get bad. So you have, I said, if you have an increasing swelling where the patient is having increasing difficulty swallowing, speaking, or talking, if you have sufficient swelling in the floor of the mouth, or the patient has a medical history of diabetes or immunologically suppressed, you would consider bumping him up the medevac chain.
Okay. And my last question, doctor, is in terms of, we see that especially in the mainland and the Amazon, there's a lot of extra beliefs. People go often do, I don't want to call it a voodoo doctor, but like herbal, medical, you name it what you want. How would you approach that if you want to treat a patient? Is there, you can overcome these obstacles in your relationship with your patients?
So basically, yes, I went to Malawi, similarly thing, Guatemala, similarly thing, Colombia, similar thing. So never underplay the local doctors or the local herbal doctors, because you may be going in and out. They're probably there for like years and years and years. Also, some of the medicines actually do work. Their analgesic stuff, which does work really well. Some of the stuff, I don't know what it is. Some of the local stuff which they use is basically very strong astringents. They use it. I would, if they are there, consult them on an equal level with due respect and discuss it with them. And more often, like we did it in Guatemala, is actually share the skills. So if you're doing an extraction, I would show them that this is why I did that extraction. This is what I do, and actually work with them rather than against them. If you think they're doing something drastically wrong, be very diplomatic in suggesting. First, compliment them, then possibly show them the correct technique, but always end with a compliment, like you do it on the ATLS course. So always get them on your side. That is what I think.
Rod, you had a question.
Yeah, Rod's question was, which was not my go-to analgesics. Was that right, Rod?
No, mate. I think everything's been covered there.
I like you mentioned the pain pack, which is your paracetamol, 1 gram, and you mentioned ibuprofen if the kidneys are okay.
Yeah. And it is basically surprising that, I mean, as as probably you'll know that in a conflict situation, we use less and less ibuprofen in that area. But it's surprising that where we've been teaching, they're using a lot of ketorolac, and they're finding that the effect of that is pretty good. So one wonders, but yes, it is theoretically just now, we do not agree in using ibuprofen simply because of blood coagulation mechanism and other factors. But at the end of the day, for teeth, you do need anti-inflammatories, and anti-inflammatories will work unless it's impossible to use it. For example, asthmatics, etc., in which the case you will have to think of paracetamol. And as Kevin was discussing, again, it'll pump you up the Medivac chain if you are unable to give certain medications for these patients. And go-to antibiotics, which Rod was, go-to painkillers, which Rod was discussing, is definitely, I would say, ibuprofen or ibuprofen mixed with paracetamol would be my choice. You can always think of cocodamol, but remember, cocodamol is a painkiller. It will not or reduce inflammation to a minimal extent. It's a good one to add or give just to top things up. But if for pain relief, you do need anti-inflammatories to go. And of course, they have to go hand in hand with antibiotics.
Any other questions for Dr. Langdana?
Absolutely fantastic as always, mate.
More than welcome, Uncle Rod.
I look forward to that coffee and Malta.
Absolutely looking forward to Malta so much. Yeah, definitely.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at corom.edu.mt.